Hello everyone, and welcome to another day of high yield USMLE questions. Today we'll be talking about endocrinology. So a 45-year-old male with CKD comes to the office for follow-up. He's not on dialysis. What are some normal labs are following? So we have the creatinine for obvious reasons is high because the patient is CKD. BUN is high and serum calcium is high. Remember, if it's greater than 10.2, that is high. And phosphate is normal, up to 4.5 is normal. And PDH is really high. I think about 60 is the upper limit of normal, so this is really high. So now they're asking about what could be the reason for this hypercalcemia. So what caused this hypercalcemia? So let's go through each of the options. So now we're talking about malignancy. So they are talking about hypercalcemia of malignancy. Hypercalcemia of malignancy. So here usually that's PT HRP, parathyroid hormone related peptide, and usually, for example, small cell cancer, this will be associated with. But remember, the problem here is that even though the PTHRP would be elevated, that will lead to increased calcium, really increase like 14 or greater than 14. But the thing is, this calcium will in turn go to the gland, parathyroid gland, and it will suppress PTH. So the PTH will be low. Here it's really high, so that rules it out. Then parathyroid adenoma. Let's talk about parathyroid adenoma. PTH is high. Parathyroid adenoma is primary hyperparathyroidism. So if it's an adenoma here, so it makes sense. Yes, PTH can be high here. Second, calcium can be elevated. Yes, it can be elevated. Can phosphate be normal? Phosphate can be normal. So we're going to keep this for now. Then we have CKD. So in CKD, the patient is having CKD, but here they said the calcium is high. Remember, in CKD, there is hypocalcemia. And that leads to increased PDH. But here we are having hypercalcemia, so that will rule it out. And in CKD, remember the reason for hypocalcemia, right? Because CKD is involved in vitamin D synthesis, and vitamin D is not there. So that's usually the reason and there will also be hyperphosphatemia. This patient's phosphate is normal, and PTH, even though that will be elevated. But remember, there is a end-stage renal disease, where these patients are usually on dialysis, where the gland becomes autonomous. This parathyroid gland becomes autonomous, and the reason for by that I mean is that it increases PTH levels. The PTH is really high, regardless of serum calcium levels. So the calcium may be elevated, may be low, it doesn't matter. The PTH is still kind of crazy high. It's just still going to. This is the reason it is called autonomous. Here, there's not be the case because the patient's CKD is it doesn't look like it's end stage now because the patient is not on dialysis. Usually these patients are on dialysis. If this patient had, then this would have been the right answer. But the patient is not on dialysis. It doesn't look like the patient having end stage renal disease. So this is not the case here. Then immobilization will cause hypercalcemia, but the thing is the PDH will be low. Osteoporosis, remember, all the labs are normal in osteoporosis. So important thing to be aware of. So hope this video was helpful, and if it helped, please like and subscribe to the channel. And if you require tutoring, you can email me here. Thank you.